Right. Good morning, and good morning, everyone. It's Dr. Mohammed here. I'm a head of scientific committee for the African Society of Vision Anesthesia. On behalf of the African Society of Vision Anesthesia, I welcome all of you.
Right.
Africa, home of vast deserts and tropical rainforests, rugged mountains and fertile grasslands, Africa, continent of exploration and beauty. So today we are all together live on the same land, and I'm really blessed to be part of this brilliant team and sharing the knowledge and spreading the old experience of vision anesthesia to our people.
So today we are all together.
So I'm really blessed to introduce Professor Amani Ayat. She's the secretary for the African Society of Vision Anesthesia, and she's a chair for the middle section of World Institute of Pain. She's with us today, and she's going to give us a small brief about the African Society of Vision Anesthesia and the certain activities we are going ahead today. So over to you, Professor Amani.
Okay, thank you very much, Dr. Mohammed. Good morning, everybody, wherever you are. We're so glad to be with you. On behalf of the whole AFSRA board, allow me to give you a warm welcome in this fruitful meeting, and I wish it will be very much enjoyable because I know the content will be very helpful. But before that, allow me in 2 minutes to tell you the story, our story, the AFSRA story. In the year 2010, group of motivated anesthesiologists from Africa, from Egypt, from Nigeria, and from South Africa, we had a look on the map, and we found that there is an American Society of Regional Anesthesia of Pain, AFSRA. There is European one, AFSRA. There is another one in Latin America, the LASRA, and the Australian one, AWISRA. But there was a beautiful continent that is missing. We dreamed of having this. We dreamed of having a society that can deliver a better education to our doctors, that we believe they do deserve a better treatment, a better education, and our patients, they do deserve a better opportunity. So we started working on that. Shortly in 2010, by the end of the year, it was launched. To our surprise, it was launched, and we kept going on the ground. Initially, we have to hold a big event every year in the form of a conference and a workshop. And by the way, this year we'll be hosting the 10th International Conference of the AFSRA. But this was not enough. We started collaborating with other societies in Africa, like the Egyptian Society of Anesthesiologists, like Nigeria, like a society from Sudan, but this was not enough to us. In the year of 2014, to our surprise, we won the bid. We were the host of the World Congress of Regional Anesthesia and Pain Therapy. And we hosted that in South Africa, in Cape Town. And 4 years later, we contributed in the organization of the next World Congress of Regional Anesthesia and Pain in New York. But you know what? This was not enough. Early this year, and I have to give all the thanks to Dr. Muhammad Mustafa, who had a brilliant idea. We wanted to reach the unreachable. We wanted to reach every doctor in Africa. And this is very tough and very difficult, by the way. So Dr. Muhammad suggested a wonderful suggestion that we can have ambassadors to be a link between the AFSRA and the doctors on the ground. And here we are. This is our baby step. The first one with this webinar. We're delighted to be with the doctors from Zambia. So we're so glad because finally we're about to reach the unreachable. So allow me to introduce Dr. Nasibu Mwanda. Dr. Nasibu was graduated from the Faculty of Medicine from Turkey, from Istanbul, but he practices currently in the UK. Dr. Nasibu, with an experience for 14 years of in emergency medicine, and he is currently the vice chair of the Tanzania UK Healthcare Diaspora Association. He conducts a volunteering work and activity everywhere just to connect and to help his people in Tanzania back. So Dr. Nasibu, the floor is yours now, and a warm thank you, a warm sense of gratitude to you because you gave us this wonderful, wonderful opportunity. Carry on, Dr. Nasibu. Thank you.
All right, thank you very much. As introduced, my name is Dr. Nasibu Mwande. I'm from Tanzania, and currently in Tanzania, as you can see, in the beautiful land, the sun is shining, it's a bit drizzly. I'm sorry about the technology. I'm not at home, I'm outside, bringing the whole show from outside. Now, thank you very much for everyone who decided to attend this fantastic webinar. And I think it'll be a huge opportunity. And I think there's a lot we can give to our people regarding analgesia. And we have a panel of a lot of good experts, experienced, and who are well and very happy to share their knowledge with everyone. And here. Now, probably, can you hear me? I think
yes.
I keep losing. Yeah. Okay. So I think we're gonna. I was supposed to be demonstrating the Fachariaka block as well as something to go along the trauma, but I think because of the technology and stuff, things are not as planned. So I think I'm not gonna take much of your time. I'm just want to say that this webinar is coming from Tanzania with collaboration with Tumbi Regional Referral Hospital in the Coast region. And this hospital, I think, see quite a lot of trauma. I think this talk today comes at the right time and to see what we can do locally and international as well by sharing knowledge. So with further ado, I'm going to introduce, I'm going to let Dr. Sonia take the floor. Thank you. Over to you, Sonia.
Right. Okay, thank you very much, Naz. Well, before we go into Sonia, I'm just going to give a little bit more about Dr. Sonia Lala. She's a consultant anesthetist in being trained in the UK. She graduated from Leicester University, being trained in the northeast of England in the UK, and she's from Kenya. She's practicing now as a consultant anesthetist in Kenya. She's very interested in regional anesthesia specialties like major surgery, perioperative medicine, complex airways. So she's passionate also about the equality and diversity, and she was organizing a very fantastic field event which is called Leveling the Field, with eliminating all the differences between the people with the different ethnic minorities. So I'm really glad to have Dr. Sonia here, and she's going to give us a very interesting talk about the safety for labor analgesia. And we're going to keep the question and answers to the end. I know that we have also live streaming in YouTube if you want to follow it. And hopefully at the end you will go on to enjoy Dr. Sonia's lecture today. Thank you.
Hello, everyone. Thank you so much for that introduction. Welcome to the African Society for Regional Anesthesia webinar. Today, I'm going to be talking to you about labor analgesia. I'll be running through things in quite a broad aspect so that I can cover as much as I can. I have put my email address and Twitter handle at the end of the presentation. So if you do have any questions or any comments or anything that you'd like to say, or if you'd like to share some slides or anything of that sort, let me know, or you can email through AFSRA and we'll be able to share a few things out with yourselves. So before I start, just saying words with no meaning, I'm going to share my screen with you. Okay, there we go. Right, so I hope you can all see the screen. I have on purpose left this presentation as bland as possible so that I can talk to you and emphasize a few points without you getting distracted with all the wonderful pictures of women in labor. So labor analgesia, are we doing enough? Before I start off officially, I have a few disclaimers. So I'm not an obstetric anesthetist. However, like most of us who have done any form of anesthesia, it is hard to keep ourselves away for any duration of time from the birthing suite or any women who tend to come in labor. It's part and parcel of our training. It's part and parcel of our daily job, our daily role, which is why it's quite an important aspect. I can't think of any anesthetist who may have, been through their career without having come across obstetric anesthesia. However, anything too niche or too specific, I'm probably not the best person to ask about. Second disclaimer is I haven't practiced widely within Africa. I have just moved to Kenya, relocated back to Kenya. So majority of my obstetric and anesthetic practice has been based in the UK. So again, please do feel free to tell me if I'm right or wrong, or if our practices differ, significantly, or if actually you see similar things within your countries and within your practices. We're all here to learn, so I'm happy to learn as I am to teach. So having said that, there's a lot that can be said about labor in itself, in terms of physiology, in terms of maternal health, in terms of pain relief itself. So I'm not going to dwell into the physiological changes of pregnancy, and I'm certainly not going to talk to you about pain pathways. I'm sure you can read up on that and refresh your knowledge when it comes to how pain is perceived through labor. However, the things I will be talking to you about are labor pains, why we need to use analgesia. We love a bit of science, so a little bit about evidence-based medicine, or the lack of, and my personal favorite when I approach anything that requires analgesia, and that's the 4 Ps. Right, without further ado, what is pain? Now, we all have faced and felt pain in various forms. There is various scientific definitions of it. The one that I'm going to use is from the International Association for the Study of Pain. This was a definition that they refined in 2020. And it says that pain is generally an unpleasant sensory and emotional experience associated with, or resembling that, associated with actual or potential tissue damage. What this tells me is that pain is not only felt currently, you can also have pain from an experience today. You can feel that tomorrow and the day after. Not only is it a sensory perception, it is also an emotional experience. So when we think about making a certain aspect of someone's life better with regards to abolishing or even just minimizing pain, we're looking at not only making the experience in the present better, but also to improve their emotional perception of the pain in order to make the future experiences better as well. And the one thing I can think of in labor is that every one of these words is relevant. It is a sensory experience. It is an emotional experience. It resembles actual pain. It resembles potential tissue damage. And so all of these factors are probably the one thing that we should be looking at why in labor we need to make things a bit better. So with that context, what is labor pain? So labor pain is known to be one of the worst imaginable pains women experience. I've put down too much experience in there. Women experience and are likely to experience during their childbearing age. The Association of Anesthetists, the American Society of Anesthesia and the College of the Obstetric and Gynecologists have actually said, in no other circumstances under which it is acceptable for a person to experience untreated severe pain, which is amenable to intervention under physician's care. So in no other situation would you let someone continue being in untreated severe pain when you have the capabilities of reducing it. So what happens when you leave labor pain untreated? A little bit of physiology here. So as with every other pain, you've got this excessive release of catecholamines, where what happens is that you end up with an increased peripheral vascular resistance, which affects your cardiac output. It decreases placental perfusion, and what you end up with is incoordinated contractions. You then end up with maternal hypertension, which when it comes to various sorts of maternal obstetric pathologies, such as preeclampsia, the last thing we need is an increased blood pressure secondary to pain. Cardiovascular stress, which automatically translates to fetal distress by a decrease of oxygen because a majority of the oxygen is being used by the mother. And because of that, you end up with less going to the fetus, end up with fetal distress, again, a situation we don't want to be in. And of course, there's hyperventilation. So in a situation where the mother is hyperventilating enough to cause respiratory alkalosis, you end up with a pH imbalance, which in itself creates various physiological changes that are not useful when it comes to any kind of big stressful situation, especially one where there's lots of blood loss and you end up with hemorrhage. So severe pain, anxiety, and increased catecholamine levels are associated with prolonged or dysfunctional labor. This has been, it's one of the studies that was done, it's a proven fact. Another one of those is that women in developing countries experience postnatal depression at the same rate, or rates that are comparable to those in developed countries. And yet we, as a continent, don't seem to be faring very well with worrying about our patients' experiences, postnatal depression, and the mental health that comes, the traumatic events that follow after childbirth. However, we know that patients have one-to-one support, whether this be through birthing partners, doulas, midwives, and physicians, require less interventions, less pain relief, and the labor is actually shorter. So what are we not doing? We're actually within the continent, or if I rephrase that, within generally low resource countries, we're not offering pain relief, and we're not educating women to the fact that they can have pain relief. So we seem to be underselling analgesia through labor for a multitude of reasons, whether it be through cost, through the lack of training of our healthcare community, whether we have no equipment to support that training and delivering of analgesia. Seem to be a barrier with cultural views and expectations within our patients who come to us, especially nulliparous patients, so patients who have not been in labor before, have these cultural views and expectations which we don't seem to be challenging too well, and attitudes of healthcare professionals. Now, there's a lot I can say here about attitudes from a variety of professionals, whether it be in big centers or even in small district rural hospitals. We seem to be letting our patients stay in pain. We seem to be not empowering them to ask for analgesia, and we most certainly don't seem to be offering them analgesia, even in the antenatal setting, to explain to them what or help with their expectations of labor. So I'm going to mention a few studies here done in a few countries. I'm not picking any countries where all as bad as each other. There was a study done in Nigeria in 2014, which looked at, it was done by their the College of their Obstetricians, and it proved that only 49% of the obstetricians were offering analgesia. That study was somewhat repeated 4 years later in 2018, where it was found that even though 78 centers, so 78 maternal centers, had an epidural, specifically this one, had epidurals available, only 26% were offering it. So quite a significant gap as to why we're not offering analgesia to women when they might not even be aware of it. There was another study done in Uganda in 2015, a pretty decent sized study of 1,293 participants, and actually only 7% of the participants had knowledge of labor analgesia. And there's been study after study showing that there's very little difference between how educated a person is or what background they come from and whether they know about the analgesia techniques that can be offered in through labor. And following that, I thought this was an interesting statement that they put there. Almost 90% of mothers who had previously been through labor did not have any labor analgesia. And just under that, so 87.9 did not have it, and only 87.7% of them said that they would want it. So very similar proportion, if offered it, would take analgesia. So we can't just blame a patient refusal or they probably wouldn't want it, or various cultural associations with lack of providing analgesia. Now, what evidence do we have? Unfortunately, there is a lack of high-powered RCTs, which made me feel a little bit like this. But lack of high-powered RCTs, why difficult to know why not a lot of studies have been done. However, there are some small-scale studies that have shown a variety of methods proven to be beneficial. Out of these RCTs, the three things that we know for sure improve outcomes or improve analgesia. Really simple. I wonder if anyone can guess. Continuous support. So a trained person having psychological and physical support. So someone like a midwife, a doula, a birthing partner, someone who is supportive and physically present, is shown to improve perceived pain. Information. So we definitely underestimate our patients, because providing prenatal information on what their experiences are likely to be and what their analgesic options are already in itself improves how painful their labor is. So why we're not doing simple things like this in an antenatal setting is something we should probably look into. yes, I understand that a lot of us end up facing patients who don't have a lot of prenatal, antenatal exposure, that, you know, late presentations for whatever reason. And that's a separate bag on its own, but majority of women within this continent do have some degree of antenatal support, and we should be looking at mentioning to them the options that are available so that they can think about it, and maybe talking to them a little bit about the experience, and how, you know, labor is perceived to be painful, and it is likely to be painful. And then, of course, regional techniques. So things like epidurals and CSEs, so combined spinal epidurals, or various techniques, doses, in various ways are known to be helpful. So now, my 4 Ps to manage pain. This is a way that was taught to me on how to approach managing pain. It can be used in an acute and a chronic situation. It requires a little bit of mental mapping of how you're going to approach pain. All of them can be mixed up. They can all be used independent to each other. They don't all necessarily have to be done by one professional. But this is how I like to think about pain, just to ensure that we can get simple things done before, or as well as, you know, more invasive options. So 4 Ps, here we go. Physical, psychological, pharmacological, and procedural. So physical, what are the things we can do physically to help alleviate pain? TENS. So TENS seems to be quite popular. It's one of those things where certain centers have TENS machines that patients can borrow out. Some people choose to buy some and have them personally. So it's transcutaneous electrical nerve stimulation. It uses the gate theory of pain in order to suppress the intensity of pain. It's known to be quite popular, especially in early labor, and quite useful as well in early labor. Immersion. So when I say immersion, I mean generally like in water. So water baths, being able to sit in a tub of water, generally it reduces the gravity effect of the gravid uterus, and again through various gate theories with water and warm water and dorsal perception, it does seem to have an impact. Massage, this is something you can get the birth partner on, or even just a simple massage from anyone who's helping out, whether it's a back massage, shoulder massage, just gentle stimulation is one of the techniques that can be used. Acupuncture, that's something that is popular in certain cultures and not at all in certain in others. It's something that can be, it has to be obviously provided by a professional who knows what they're doing, and obviously only in certain situations. Birthing bowls, posture, various postures, being on all fours is meant to be a favorable posture for analgesia purposes, but also to fasten the birthing process. Sterile water blocks. I've not experienced these myself. I've not come across anywhere in England that does them, but they do have their role. And what I gather is that these are small volume sterile water subcutaneous injections that are used around the sacral region of the back, around those dermatomes. Again, uses the gate theory in order to alleviate pain. Psychological, what can you do? Having a midwife present, having someone professional present during the birth is a psychological reassurance for the person going through the whole physiological change. Birthing partner doula, I think I've mentioned this a few times. Music, a little bit of gentle music, a playlist made by the patient themselves, something calm and soothing, something distracting, also has a small role to play. Aromatherapy, so smells of various sort are known to help. Towards the end of the presentation, I have a table which is going to tell you a little bit about certain smells that you can use. Well, it talks a little bit about all of the non-invasive procedures and a bit about their studies. So we can look at that a little bit more. And hypnosis, again, requires an allied healthcare professional to provide this technique. Pharmacological. Now, I know we're all people of science and we love to get into all the medications. And for that one reason, I'm not going to talk too much about medications because I would like us all to focus on alternatives as well. So supporting bits of therapy that we can provide other than just the drugs that we thoroughly rely on. Having said that, Entonox gas and air is popular all over the country. It's one of those things, all over the world actually. It's one of those things which is easily available, requires less training, can be used by patients, supported by any staff, doesn't need direct observation. Of course, you need to be a little bit concerned about kind of ventilation and scavenging, the effects it's having on Earth, because we all know what climate change is doing. In addition to the inhalation aspect of Entonox, there's certain places that use a small amount of inhalational agents. So a little bit of isoflurane, a little bit of sevoflurane. This, however, of course, does need monitoring, and you have to be wary of the scavenging aspect of this. It has been shown to provide analgesia, whether it is in the form of a slight bit of sedation and dissociation, but it does have a beneficial outcome. Non-opioids, so simple things working up the WHO ladder, paracetamol, non-steroidals, antispasmodics, and sedatives, especially in the early stages of labor, when you're not required to do too much, might just be one of the things that tie them over to buy some time. And then, of course, there's opioids. So within the UK, a lot of the midwives are able to give intramuscular injections. So a lot of these can be given without any doctor, either prescribing it or giving it itself. And that's things like morphine, diamorphine, pethidine. Stronger opiates and synthetic ones such as fentanyl would have to be overlooked and tend to be given parenterally through the IV rather than intramuscularly. There are some more that I'm not very familiar with using myself, especially through labor, other than meptazanol. So we have used Meptid again through a midwife-led unit, but there's all sorts of opiates that you can use. Of course, when using opioids, you need to be prepared for these to be passed on through the placenta and for possibly either sleepy or respiratory depressed babies when they arrive. PCAs, so you've got the patient-controlled analgesias, remifentanil and fentanyl, which are one of the new age options we give our patients, especially when things like regional techniques are not appropriate or they're contraindications for giving them. However, they have huge safety issues, and you need to be, have your patient under very strict monitoring. So for that one reason, they're not one of the most popular means of giving opioids. Procedural, and then of course we have our epidurals, our CSEs, and I've put this in brackets, caudals, because I've not seen caudals being given for labor analgesia purposes, given that epidurals work so well. There's obviously that high risk of inadvertent intrathecal injections with caudals, and of course intravascular ones too. Epidurals have certainly have their role, and I'm sure all of us have our spiel of consent and things that we talk to our patients before we give them an epidural to help with analgesia. And there's various techniques. It would be great to hear back about any other techniques that you use within the epidural, so dural puncture epidurals or just straightforward epidurals, whether you have them in a continuous infusion or whether you do patient-controlled ones or both, and same with CSEs. Again, everyone has a different technique in which they use with the CSE, especially in terms of proportions of what they put into the intrathecal aspect as well as the epidural. So those are one of our options. This is the table I was telling you a little bit about, which looks at all of the non-pharmacological options of giving analgesia, a little bit about the mechanism of actions, and this corner here is where we're looking at the evidence, which again, there doesn't seem to be too much of, but for women that use a combination of these things, some of them swear by it. We know that this has certain improvement in their outcome. When you go see them the next day, they have certain women, you know, believe that certain things worked for them. And it is a lot of this is to do with subjective pain relief, rather than objectively being able to reduce pain relief, because we know everyone's perception through labor is different. But the end of the day, when you have a patient who is satisfied with the analgesia that they got, with the, you know, the attention they got and the care that they received, the overall outcome of making that experience favorable for the person, so that if they were to choose to come back again and have another child, you're eliminating a huge aspect of anxiety and post-traumatic stress for them. Right, so my take-home messages. So we are underutilizing our analgesia techniques, either due to a lack of demand, whether that could be due to lack of awareness, or because we're just focusing on things other than analgesia, perhaps because we don't see the importance in it. Again, I've plugged in this a little fact here. So there was a study done only 2021, where only 8% of women that were spoken to, went through this process, were aware of various, or if at all, any analgesia techniques that can be offered during labor. Cost does not have to be an issue, and this is why I did not specifically focus on the pharmacological aspect or the procedural, because I want us all to have a little think about the alternative therapies we can also use in order to make the experience better. We know pharmacological agents work, we know procedural ones, we know epidural CSEs work, and of course they have their roles, which is proven, but there's a lot of other things as well that, you know, if we are in a situation where we're in a low resource setting and we don't have epidural pumps, so we can't get people coming in and monitoring patients and strong opioids as frequently, then there's alternatives we can do. So I would like us not to think just of cost as being a roadblock to this. And of course, there's a big cultural aspect of why is it that women are allowed to be in, or are allowed to be in pain. Yes, we've had babies throughout time, and we didn't have analgesia back then, but we do now. So perceptions such as it'll make me love my baby more, or it'll have a negative impact on our baby, or no one in my family, my mother, my grandmother, my great-grandmother didn't need it, why should I need it? Or I need to experience the pain of natural childbirth to be accepted within the community. These are perhaps notions we need to question, maybe. Maybe it's time that we change the narrative of what is allowed and what isn't allowed for women within our society. Perhaps we should be pushing and advocating for our patients a bit more if they don't know that actually a lot of our techniques are safe for them, they're safe for their babies, and they're not going to have an impact on, childbirth. It's not, an epidural is not going to make it more likely for you to have a cesarean section, then perhaps they'll be less worried about accepting them. So, yeah, these are my take-home messages, and maybe we should be communicating to our patients a little bit more about their experiences or their ideas of what labor is going to be like, what their concerns are, and how we deal with those expectations overall. And I hope by the end of this, you feel like this cat, who is standing in a very unfamiliar situation with lots of challenges around it, but looks pretty brave enough to take them on. So thank you very much. There's my email address and Twitter handle. Feel free to message me any questions or comments, and I will either try to attend through the AFSRA platform, or I will share back with you. I will stop sharing the screen now.
Right, thank you very much, Sonia. This was a really good, comprehensive, and it's one of these fundamental aspects of a safer approach to parturients, which is we are all a lot of African countries, we have lacking of the concept of how we have to aggressively managing pain in obstetrics. And we'll have the question and answer at the end, and let us just move now to another fantastic speaker, is Dr. Shabani Majaliwa. I'm really pleased to have him with us today. He's a consultant anesthetist in intensive care. He's a former resident at Lille Hospital and Amiens University Teaching Hospital in France. And he is a senior anesthetist now in mobile surgical team, a surgical program run by the Red Cross, International Red Cross, ICRC, for weapon wounded patient in Maiduguri state in Nigeria. His career and accomplishment, he has a lot of accomplishments. He's been working for IC for 7 years now. His special interest in capacity building and regional anesthesia and closed loop anesthesia and scopion envenomation, so in low resources setting, plus the point of care ultrasound. So I'm glad to have him here today, and hopefully you're going to enjoy this meeting. Thank you very much.
Yeah, good evening, good morning, everyone. My name is Shabani, as been introduced earlier. Yeah, it's a great opportunity for me and on behalf of AFSRA to discuss with you or to present to you about acute pain management in trauma patients, specifically for weapon wounded. This is somehow AFSRA experience. Yeah, AFSRA is a humanitarian organization, and we work to ensure humanitarian protections and to make sure that the patient or the population affected by conflicts have a good support from the organization. Yeah, when it comes to AFSRA hospital projects, sometimes people are a bit afraid to know that you have to work in low resource context. In fact, if you see on your left, this is our basic setups. And in our standard setup, you have syringe pump, you have basic monitor with standard features like HU2, SpO2, no invasive blood pressures, and so on. And on your right, we have, if possible, we try to set up a dedicated area for regional anesthesia. So this space is very important when it's come for capacity buildings, because it gives us opportunity to have all the times to teach other colleagues, other residents, and nursing about regional anesthesia because you can perform your blocks before, you resume the procedures, so you don't really have to fight for the OT, the surgeon. You have the time to teach and train and hands-on experience. So, but when it's come really to work in this context, you have to know that you don't have all the resources as in civilian hospital. You may have some limitation regarding some drugs or not all the drugs you can use. So you have to always try to weigh your risk benefit of each drugs you can use. And it's very important that you know your limit and you shouldn't harm. That's the most important message. So why pain control is important for surgical patients? So it's help really early ambulation and rehabilitation. It improves healing process and prevents some surgical complication. It prevents stress, anxieties, and the involvement of chronic pains. And also, as the patient is more active ambulating, so there is help really to prevent DVT and the pulmonary embolism. Overall, you have your patient who is happy and will be discharged and go back to his normal activity. It's really a virtuous circle. So we're going to talk about principle of perioperative pain management, preoperative pain management, intraoperatives, and postoperative pain management. And briefly, we talk about uncontrolled severe pain, what the strategy you can have while working in the field or in low resource settings. And we'll finish by a summary of perioperative pain management in AFSRA setting. So when it's come to talk about perioperative pain management, it relies on the following principles. First, multimodal analgesia, procedure-specific analgesia, assessment of pain, enhanced recovery after surgeries, and preventive analgesia. So multimodal analgesia give a lot of advantage due mainly to these synergistic effects, and it really have a opioid sparing effect, and you have less also side effects because all those are reduced, and you can use the synergistics to have a good, optimal pain management relief. So in RCRC multimodal analgesia, so we use different components, pharmacologically and non-pharmacological components. When it's come for pharmacologically component, we use mainly ketamine that can be used at sub-anesthetics dose at the bolus, depending on the length of procedure, can give ketamine at the bolus, followed by the infusion. The same for ketamine, the same for lidocaine, magnesium. And also we give dexamethasone as single shot. Beside adjuvant, you have some basic analgesic as ibuprofen, diclofenac, and paracetamol. Sometimes in post-operative period, if we have some neuropathic pain profile, you can use gabapentin as preventive measure, or you just has to treat neuropathic pain if there's any neuropathic component of the pain. And mainly you have opioids, morphine, which is gold standard for acute pain. Sometimes in post-operative period, we can use low dose of fentanyl to relieve the pain. And we more and more in our setup, we use regional anesthesia in pre-op, intraoperatives, and post-operative pain control. Beside for pharmacological components, there is also no pharmacological components, mainly psychological support, and rehabilitation. And this rehabilitation is really, really important, mainly for children. So we try to have the children have a normal life, with the support of psychologists, social worker and psychologist. So regarding procedure-specific analgesia, I will emphasize mainly for children to really try to avoid any stress regarding cannulation, change of dressings when it's become repetitive, and also to try really to make children's return to a normal life, despite he's still in our hospital set. So for instance, for IV cannulation or blood drawings, we use MLR creams. So sometimes, for instance, in pre-operative area or in preparative setup, in the recovery, we have a dedicated place for children. This is what you call children anesthesia-friendly environments, when we try to create really an environment where the children can feel really secure, and they can have some small toys. They can use some iPad with some games in. So it's very, very important to at least to decrease the stress related to this environment. To decrease the stress related to operation room theater environments. So regarding enhanced recovery after surgeries, this is how we do it. We try really to optimize perioperative fluid and body temperatures. We avoid as much as necessary some surgical drains, nasogastric tubes, catheters. We do early enteral intakes and early supported mobilization. For instance, in cesarean sections, it becomes really standard not to wait 6 hours before we initiated oral intake. If there's no any complication, any issue during the procedures, C-section mainly, we allow the patient to take the fluid straight after they are discharged from the OT. In the ward, they can take straight away, clear fluid, and after 6 hours, they can take, normal food, light food, yeah. So assessments and reassessment of pain, this is very important because this is the only way you can know how your intervention is, are you effective or you are not effective. So in our settings, if we receive a patient with acute pain, so we try really to assess before the intervention if it's morphines or other things. After the intervention, we do at least 4 times a day as assessment. This is also true for during post-operative periods. After that, in normal routine, we do 2 times per day follow-up about the pains. This is the same as all vital sign. We do the same for pain, at least 2 times a day. Yeah, and once a week we perform what we call pain rounds. So this is very important to do a follow-up with those who have somehow neuropathic pains, because you cannot relieve the pain, and one day you need either to increase gradually the dose of some drug like carbamazepine or gabapentin or amitriptyline. So when it's come to preoperative pain management, morphine really is a gold standard. In our setting, we try to use IV as much as possible. We initiate by titrations. When the patient is relieved, we switch to subcutaneous. We don't use patient control anesthesia, IV patient control anesthesia, because of limitation in terms of follow-up. Yeah, this is a reality due to the environment we are working, and we are not sure that all the nurses during the night shift, for instance, they'll be really at ease to follow this kind of patients. Or if there's any issue regarding the machine, if they can know how to change it, because most of the time you will not even be there to do a follow-up at night shift. And beside, we try to teach all the staff about the complication of morphines and how to initiate it, the treatment of overdose. Not only to monitors, but also how they, with the protocol, how they can treat any overdose related to morphine. And we make sure that naloxone and basic airway kit is available whenever morphine is used. And all our patients on morphine are followed by, we have a basic monitors, and also we assess sedation score. And yeah, this is mainly what we are doing to avoid any complication related to morphine. So this is our chart we are using, somehow flow chart regarding the management of morphine. Yeah, there's a pain score, sedation score, and dilution. Yeah. So for pre-operative pain management, we can use also ketamine 0.1 to 0.2 milligram kilo every 20 minutes. This is really sometimes help to reduce pain score and also to reduce the total dose of narcotic if you are using, for instance, morphine. If you combine with low dose of ketamine, it helps you to reduce the total amount of morphine that you can use. Yeah, but you have to consider mainly ketamine when you have hemorrhagic shock, respiratory distress, and if there is any significant risk of developing either condition. So you should consider when the pain is not coming under control after morphine. Sometimes if the pain is not controlled with morphine, adding some low dose of ketamine and might help you to control the pain. So for intraoperative pain management, first we are going to talk about regional anesthesia. And I will emphasize on some particularities of regional anesthesia for weapon wounded. When it comes for weapon wounded, it's different from civilian because the lethality of wounding agents, you may have patients who are victims of improvised explosive device. You may have some bomb blasts, injury, landmine, gunshot, and also the anatomic distribution of wound. So sometimes you have patients who may have chest injury combined with abdominal injury, combined with, extremities injury. So, and most of the patients arrive not just after the injury. Sometimes you may have critical patients, not because of the injury, but because of the delay. The patient may wait 2 or 3 days before they manage to arrive at the facilities to have their surgery. So, and mortality is really high regarding what we have been talking about. You have patients really are polytraumatism. They have really, really many injuries, and pre-hospital and post-operative mortality can be high compared to civilians' traumatism. And sometimes you have some disruption of normal anatomy. You may have some patients who have all the upper extremity blown up, so it's really difficult to sometimes to treat these patients because you have some patients with trauma of upper extremity, with a trauma with head injury, with trauma of lower extremity, abdominal injury. So it's not really as in civilian life. So this is a list of our most common block in the field. So the basics that someone to work really, that the basic block, if you, for instance, we usually use in the field, you have axial brachial plexus block, you have femoral nerve blocks, adductor canal blocks, popliteal sciatic blocks, erectospinal blocks, fascial lacca block. Fascial lacca block is very important, mainly for preoperative, for instance, to control pain related to the fracture of the neck of the femur or the femoral traumas. And yes, and also it's important to fascia iliaca is very important for postoperative pain. You may use a spinal, for instance, for hip fractures, but after you finish the procedures, you can also use fascia iliaca blocks for pain management as a post-operative pain management strategies. So basically, this is axillary blocks, and I'll emphasize on the landmark. You see, the landmark is congested tendon, the head of humerus, axillary artery, and axillary veins. So to give you some tips when it's come to do axillary blocks, we should do in these orders. First, you try to block the musculocutaneous, then the radials, and ulnar, and finally you finish by medial nerves. So it's also very important to not put much pressure on the probe when you are doing this block, because the target, the nerves and vascular and the vein, they are very superficial. So when you put a lot of pressures, the vein collapse, and sometimes you can be in the vein and you may not see it. You may not see because the vein is completely collapsed due to the pressure. So it becomes really a problem, and you have the risk of local anesthetic systemic toxicity. So you have to really to make sure that you are not really compressing the vein around the artery. And also you may know that sometimes there is in 16% you have variation of musculocutaneous, which is still at axillary, still within the nerve bundles. Within close to medians, close to median nerves. So this is about supraclavicular blocks. It's very important to see the location, how we do it. We prefer to do it in plan, from medial and from lateral to medial. And the most important landmark are the first rib, the lung, and sometimes you can see the pleura sliding with sliding motion in inspiration and expiration. Another important landmark is supraclavicular artery, and the bundles is located lateral to subclavicular artery. So this is very important. You must mention that with these blocks, you have to be very careful, because you are very, very close to pleurodome, so there is a risk of pneumothorax. So, and whenever you inject, you feel that there is a lot of pressure, you need to change the direction. And at all the time, you should be able to see the tip of your needle, which is very, very important. Don't move the needle if you don't see the tip. This is very, very important. Here, I'm going to talk about sciatic popliteal combined to adductor canal. This is very important blocks when it's come to for the patient with below knee injury, because it helps you to avoid even spinal if you come when you have unstable patients. So with this block, it helps you to do, lower limb surgery. Sometimes in stable patients, as with ultrasound guided, we can reduce really to minimum the amount of local anesthetic. We can do bilateral sciatic popliteal combined to adductor canal blocks, mainly for unstable patients. So the main tips regarding this block is that the patient in spine position. With this position, we have a lateral approach, as you can see on the picture on your left, and you have the needle, which is perpendicular to the probe beam, and it allows us to have a good visibility of the needle shafts. So also in this position, you can also, without moving the patient, perform your adductor canal blocks. So it's very important when you are scanning for sciatic popliteal nerves, you can try to inject at the initiating when the sciatics start to divide into between sciatics, popliteal, and common perineal. It's very important. And the block, as you can see in the picture, the needle tips it within the two inside the perineal sheath, which is very important. You have a very, very onset. It's very quick to install your block. So during the intraoperative pain management, you can also perform wound infiltration. This can be done by the surgeons. For the same, this can be, we use mainly level bupivacaine between 2 and 20 ml with a single injection. And for instance, in cesarean section, we can do infiltrations. Otherwise, if you cannot do infiltration at the end of surgery, you can do your tap block. And it's really very, very important when you have to do, for instance, if we enhance recovery after a cesarean section. That's the part of our protocols. It's relieve, very, very, it's relieve the pain for the patients. During intraoperative pain management, adjuvants are very, very important. Depending on the length of surgery, we can do a combination of these drugs. As you can see, we can give lidocaines, bolus plus IV infusion. For instance, in our settings, we give a bolus of 2 milligrams kgs of lidocaine, followed by 1.5 to 2 milligram lidocaine per kilo per hours. And also we can start by ketamine. We give a bolus of 0.5 milligram per kilo, followed by 0.2 milligram per kilo per hour for ketamines. The same magnesium, we can give a bolus of between 30 to 40 milligrams IV bolus, followed by IV infusion. And we give, regarding if there's no any contraindications, you can also give NSAID drugs like diclofenac. So also we give dexamethasone, which is very helpful for nausea vomitings. So in post-operative pain management, we use what we call reverse pain ladders. The concept is that pain is more severe immediately after surgery or after trauma or any acute medical illness. So the pain gradually decreases over the time and with the healing. So this allows us a gradual reduction in analgesic requirements. So it means when you have a mild pain, you can use a step one. You use paracetamol plus NSAID drugs like diclofenac, ibuprofen. When you have treatments, moderate pains, it means you go to step 2. You can use the same drugs as in step 1, plus weak opioid or low dose of strong opioid oral. So when you have a severe pain, so it means you are on step 3, you can use morphine, PO, IV, or subcutaneous. And when you have uncontrolled severe pains, this is mainly the time you can use ketamine plus regional anesthesia. Sometimes we have to bring the patient in the OT because he has a pain, acute pain, severe pain, which is not relieved despite morphine and ketamine. For this kind of patient, we do, at least once a day, we can use a block. This is true, for instance, for below knee amputation or above knee amputation with a neuropathic component of pain. This is our protocols, what we call reverse pain management for the post-operative pain in adults. There is also the same for pediatrics. We just talk about this one. As you can see, if the pain is severe, you use morphine plus paracetamol plus ibuprofen. When it comes to uncontrolled pain, you have to add ketamine and see the possibilities, if possible, to do a block. Moderate pains is the same. You use weak opioid plus paracetamol, ibuprofen. You can see that in our setup, when it comes to morphine, we mainly use in recovered area or high dependency unity. So when you have moderate pain and mid pain, all those drugs can be managed in the wards. So we are going to talk about infraangular fasciitis compartment blocks. This is very, very important block. And with this block, you can use it, for instance, during the pre-op period. For instance, if you have patient with fracture of the knuckle of the femur, which is very painful, in order to do your spinal anesthesia and to avoid the pain during the position of the patient or during the transport of the patient, you can use infraangular fasciitis compartment blocks, which is very, very effective in this indication. But also in post-operative period, you can use also these fascia compartment blocks. For instance, for patient who has a femoral fractures, if you have above knee amputation, it's very, very effective block. Yeah, I want to show with you as you can see, you have to be on top of iliac muscles. You have to try to find this space and see the spreads of local anesthetics. And you see the tip of the needle is a bit far from the femoral nerves. And to make sure that your block is working, you should have the spreads backward and forwards. Backward to below sartorius muscle and forward towards femoral nerves. This is very important to have these spreads all over of local anesthetic. So in summary of operative pain management in AFSRA, it means that yes, in all patients except contraindicated, in pre-op assessment, we should do pre-op assessment and physical exam, and we try to adjust or continue when possible if there's any medication whose sudden cessation may provoke withdrawal syndrome, such as opioid. Because in some area, you may find some patients, they are combatants, they are fighters, but beside this, they are also addicted. So for this patient, you might be very careful not to stop abruptly, and you may have some withdrawal syndrome. So you need to be careful. So we have to treat pre-existing pain and acute if it exists when we have patients at preoperative with acute, really acute pain. You have to use morphine, and if possible, if it's not relief, you can add ketamines. And in some patients, you may consider regional anesthesia. For instance, if you have to move patient for medical evacuation with fractures or wound on the femur, you can give faciliac blocks, which is very important. Sometimes even if you have to move a patient with upper extremities for medevac, if there's any possibilities, you can also give supraclavicular blocks, which work very well in this condition. So in intraoperatives, except when contraindicated, we use mainly fentanyl, paracetamol, diclofenac, and we can use ketamine, dexamethasone, lidocaine, bolus, and continuous intraoperatively. When there is any indication, we can use wound infiltration, mainly for laparotomy and cesarean section. And in some patients, we can consider only when indicated the use of regional anesthesia and adjuvant, as I mentioned before, I mean lidocaine and magnesium. So thank you very much. This is briefly what I want to share with you about our experience regarding the management of weapon wounded. So I should mention, for those who have are French speaking, if you have any question, you can ask your question in French, and I've tried to translate it in English and give the answer in French and English. So thank you very much.
Right, thank you very much. To Sonia and Dr. Shabani, that's were really, both of you were fantastic talks. I really personally enjoyed it. And Dr. Shabani, are you around just for Dr. Sonia? Are you around just for coming live? Yeah. Shabani, are you here?
Yes, I'm here. Thank you very much.
Okay. Fantastic. So thank you very much for both of you. Honestly, I really enjoyed it. Both presentations are great. And I think we have some questions. We'll go ahead. I know you are all busy, but just we'll try to get it as quick as possible to make the relevant. So Sonia, you had a very excellent talk about the safer approach and the pharmacological, non-pharmacological treatment of for obstetric pain, and this is really a very hot topic, especially in Africa. And I know that there's been a lot of legalities regarding how we can approach the bacteria and what's the concept. And I like that you're emphasizing the way that this is not something, not an option. This is a mandatory, and this is something very important in approaching parturients. So some of the questions which come over to me, the question is saying, what's the steps you can think about, Sonia, for safer epidural service in low resources areas? So if you are, I think the question is rephrasing, if you're planning to start an epidural service, because epidural is always having this sort of complication and problems. initiating. So do you have any guide or anything just for starting a safer epidural in low resources area?
Sure. So I can only maybe suggest a few things. A lot of this will depend on how much you have within your system. I'd like to think of it as things that you need to get sorted out within the system, and then things that you need to sort out within equipment and training. So within the system, I think the first important step is to get a multidisciplinary team involvement. So not only have the team anesthesia on board, because we'll be predominantly the team running that service, but also having the midwives and the obstetricians on board. And coming out of some of the Q&As and chats, it sounds like that may well be the biggest, the hardest step to kind of get forward, getting everyone on board. Once you've got that sort of thing, having a really good think about what protocols and guidelines you need to set up that suits your setup, so your system. There's no point picking up a protocol from a different setting that might not work for your system. So have a little think about that sort of thing. There's plenty of evidence to suggest, using epidurals does not have an impact on how long labor is, or how any sort of outcomes. So whether having instrumental or cesarean section, it doesn't really have a role to play in that. So we can put that sort of fear aside. And then there's things like having regular training embedded within the system for the staff before you start off something like this, having enough people on board. So knowing where to draw the lines. So let's say, you've got 2 pumps that you can utilize. That's the limit. You're not going to push and put epidurals in 4 people and swap and change your pumps. You need to have that safety border drawn up. And then, of course, things like equipment. So you need to be able to have enough of equipment, having the epidural, the dose, the concentration. Think about all of that before you set that up. What works for you. Perhaps avoiding opiates in the epidural, so that you don't have to have that extra level of monitoring or that worry, that kind of thing. So, and then, of course, as with every new system, you need to audit the system to see if it works, follow your patients up, follow the outcomes up, see how you can improve the system. And that's generally how I would think about going about setting up a system in any fashion, in any system. I hope that's a little bit helpful and is a bit similar to what you would do.
Yeah, that's fantastic, and I think it's the same. It's managing pain doesn't prolong labor. This is the ultimate message we need to deliver. It's a humane thing. It's just something which is being approved, and there's a strong, extremely evidence that managing pain in obstetric is actually a solution and treatment for a lot of obstetric problems, and one of them is preeclampsia. So that if you have a preeclampsia or have even other things like maternal heart disease, obstetric management of labor is management of pain in labor is quite important. Now, so what's the local anesthetic if you are going to actively activating your epidural for cesarean section per se? Do you have any recipe or any local anesthetic you use if you activate it?
There's 2 main ones that I use. The ones that I use quite commonly, especially in the UK and possibly worldwide here, is an increasing dose, but up to about 20 mils or so of 0.5% levobupivacaine. Obviously, you need to make sure that your patient is monitored, you're in a safe area, and there's no other contraindication, and that you're happy that your epidural is actually working. There's no point topping up an epidural which is patchy or is working inadequately, because inadvertently you will not get an adequate block for cesarean section. One of the other methods that's gaining a lot of popularity, possibly because it works maybe just that little bit quicker, is a combination of lignocaine and adrenaline. So this one is again up to about 20 mils or so of 2% lignocaine mixed with 0.1 mils of 1 in 1,000 adrenaline. So you pre-mix that and you top your patient up accordingly, systematically 5-10 mils at a time to achieve your adequate block.
Yeah. Do you do any spinal neuroaxial for obstetric bleeding or any suspected obstetric bleeding?
Yes and no. It depends how much the bleeding is, how urgently you need to go to theatre, how much of resuscitation is being done, if there's any other contraindications. As with everything, you have to balance your risks. So if you have a patient who is bleeding, but not profusely, or some retained placenta or something, so there's a trickle of bleed rather than hosing out, and you've got some time to create a stable situation with fluid resuscitation or blood resuscitation, then you would rather do that. For me personally, I would rather do that and do a spinal anesthetic than jump into general anesthetic. Of course, you have patients where their airway risk is higher than any other hemorrhage risk or cardiovascular instability. So you would manage that accordingly as well, depending, again, on the time and the situation. So there's no hard and fast rule with anything really, especially in obstetric. It is all just about balancing the risk and doing what is safe in your hands.
Yeah, right. So we have another one from Dr. Ahio from Gambia, which is about the quite tricky one, which is, I don't know if it's about the cultural concepts for women which is facing pain during labor to show their strength. There seems to be resistance. There's some form of resistance on the concept of pain control in some areas of Africa. So do you have any sort of, I think this is kind of, as Dr. Pa, I think from Gambia, I think this is a very good question, because it's always, I almost also had this problem when some poor in villages and poor areas in Egypt where we used to practice obstetric anesthesia, where there's some sort of, I think you emphasized this also in the presentation about how the mothers are just don't have this culture that my mom and my grandma just already having labor. So why I'm getting something different?
It's difficult, and it's not an easy, cultural myth to challenge, but it's one of those things that I think we will have to keep persisting with. We have a lot of data now. We have a lot of advances in technology. We know that, we're getting better at maternal mortality. We're doing things in a way that is making childbirth safer, or at least we're trying to. And part of that process may well be analgesics and our developments within medicine to make having children safer and better tolerated. In an ideal way, you would talk to the patient about this before they're in labor somehow, through an antenatal setup. Of course, that's not possible all the time. And majority of the time, we're just presented with patients who come in with these ideals. I think we underestimate the support network a patient has. So the partners that they come in, whether it's their mums or their other women within the society that come in with or are present, and speaking to them in conjunction with the patient can also be helpful in convincing the laboring woman when it comes to the fact that analgesia is not your enemy. It's not going to do harm to your baby. It's not going to do harm to you. And I think that's probably the base that we need to focus on, that analgesia is not a bad thing, and it's not going to do harm.
Yeah, excellent. Thank you very much. Right. Dr. Shabani, we have some questions for you. I don't know if you have seen this in the chat box. It's just saying about things about the in areas where there's no ultrasound machine. Is it safer to do landmark? I think it's not under. I think it's landmark anatomy techniques for upper limb and lower limb blocks.
Yeah, thank you very much. So I think it's not safe today's 21st century to use landmark technique regarding the risk of local anesthesia systemics. And mainly he mentions in low resource settings, when you don't have enough capacity for resuscitation. I think for me, if there's any alternative technique like general anesthesia with ketamine, it's safer to do it than doing landmark techniques. I think we have to push people to invest in low cost ultrasound machine. They are very common now. I think we have to push on this. Thank you.
That's great. Yes, I agree 100%. Thank you very much. This is I like the way you mentioned that it's really don't make harm if you are not if you have a problem in understanding or using a new technology or using a machine. Sometimes if you don't have much experience, you don't have much, you may cause harm. So sedation and general anesthetic is often a good option as alternative option. Right. So personally, for food surgeries and food injuries, when there's blast injuries in the foot, the trauma and emergency service, you prefer doing ankle block or single shot popliteal?
Yeah, it depends on the number you have. Normally, if you are not very busy and the patient need to be, to move as ambulatory surgeries, ankle block is much better. If someone has to move, if the patient has to move the same day, but if this patient has to stay in the hospitals, most of the time I do single shots popliteal.
Yeah. Shabani, this is for me, for myself, just a question. Which the common block, just out of interest for you doing an emergency service, emergency trauma patient, the most common blocks?
The most common blocks in emergency situation, we do supraclavicular blocks or infraclavicular blocks because it gives you anesthesia of the whole upper limbs. Another block we usually do mainly in emergency to relieve the pain is fasciaca iliaca blocks, compartment block, which is very effective. And if you want to, for instance, to relieve the pain and at the same time use the block for surgery, in this case, if it's a below knee injury, we use popliteal block combined with adductor canal blocks. Mainly, if you master these three techniques, you are able to do most of the upper limbs and lower limb surgery. Thank you.
Excellent. That's fine. Right. I think we managed most of the questions here. So, guys, thank you very much. This was very. Both presentation was actually spot on, and this really, really good. And
Sorry.
I personally enjoyed it. Yes, Sonia.
Dr. Mohammed, I'm going to just very quickly, I noticed there's that one question in the Q&A which we didn't quite get to.
Yes, they have. I'm sorry.
I'll just be very quick with this one. It's a very tricky one, but I think the bottom line is we have to advocate for our patients' best interest. If we have data, which we do, to suggest that analgesia does not prolong labor and does not complicate labor, then we really need to be pushing for it. You just have to be persistent, unfortunately. If your obstetricians would like to see data, feel free to arrange a departmental meeting where you can perhaps present something like labor analgesia and the evidence based around it, or even do audits to say, look, we gave so-and-so women epidurals, the outcome was not any different to the other patients that did not receive it. And maybe approach it in a more scientific fashion like that. I hope that also helps answer that question a little bit.
Excellent. Yeah, surgeons making trouble everywhere. Right. Okay, that's fine. So, thank you very much for both of you. I think we really very appreciating what you've done for us today and for all Africa. And hopefully, this is not going to be the last time. So it's going to be repeated again, more and more topics related to division anesthesia. So thank you very much, all of you, and for all our attendance. I'm just going to remind you that we will have the recording available on our website in the e-learning part of the AFSRA.net, and also the live streaming on our YouTube channel is already available. If you want to go back to the recording, also we are having the next webinar, which is going to be next month. So we're going to be uploading our Twitter account and website. It's going to be completely in French, and we have also very fantastic speaker who will give us some interesting talks. It's going to be a surprise. So thank you very much all, and have a nice day. Thank you very much. Thank you, Sonia.
Thank you.
Have a lovely day.
Thank you. Yeah.